management to knowledge management. So that's especially in industry and commercial companies. So I want to know whether this could be important also in health sector, and whether there are similar changes, if you know, in any Ministry of Health or Department of Health in any country. The second thing is, you mentioned about sometimes it's a bit complex. So when we say that mortality, deaths are, we don't need sophisticated methods to detect mortality, I don't really quite agree. In the year 2003, when the heat wave in Europe was there, France reported extra 15,000 deaths. It wasn't, that was not an easy thing, because they could have passed without notice unless we had a sophisticated system to detect that the cause of extra deaths are due to heat wave. When they did the same system in Greece, they discovered that there were deaths also in other countries that they passed unnoticed. The underlying cause was heat, was not other types like stroke. So I think we should interpret cautiously whatever information or data we have, and interpretation is not always easy, even if the outcome seems to be an easy one.
Can you go to, yes, please. There are two hands, so first yourself, and then, yes, please go ahead, sir.
In the UK, they designed few database system across the nation, which is proven to be very costly and expensive, and still it is in the process of producing. My question is, if you were going to design a system of database in Libya, in the current situation that we are in, what we exactly would be looking at?
Yeah, sure. Yeah. Try and remember.
My questions. First, thank you. Very interesting and excellent presentations, and very topical as well. A question to the first speaker is about the amount of training required in terms of setting the scene for introduction, the electronic patient records. From my experience working in the UK, it does require a huge investments, not just in the hardware, but also in training staff. We have to remember that we do not have the same level of supporting staff in terms of credentials, experience. The electronic health patient records introduced in the UK on the background of a strong national health service system. We're still struggling with having sort of paper drug charts in some of the hospitals. So this has to be considered in terms of this, and budget has to be allowed. I'm not saying this that we shouldn't do this, but we should think about that and budget for it carefully. And I think the same applies for the database as well. Every graph we've seen in any of this presentation has a lot of time and money spent for it to be produced, and that has to be accounted for, not just the software or hardware. Training of the staff is essential. Thanks.
But you didn't mention what exactly solution, an IT solution that you use. Have you developed this system in-house, or do you partnered with the software development company, or you just used a ready software and you tune it just for your
PIC system that I talked about, so that you can drive real power and knowledge out of the system. The second question, which was sort of alluded to the national programme for IT, we, as an organisation, we chose not to actually comply with the national programme. We didn't introduce the main systems. We actually had a number of discussions with the companies that are actually supplying the national solutions, and we realised fairly early that the national specs for the solutions were actually a much more diluted version of what we were already developing ourselves, so we thought it was a retrograde step, albeit there were one or two parts of the national programme, like the imaging system, the PAC system, where we looked at the specification, we looked at the systems that were being developed, and we actually did go for the national solution there. So we chose a pick and mix approach, but the main, I'd say 80% of the systems that we use to support clinical quality in the organisation have actually been developed in-house. But I did say that there are some systems out there other than our own that can actually do a similar job if you actually design the tender specification appropriately. In terms of training, I do pick up and agree with your point about you can't just plonk a system in there and expect it to work for day one. So part of it is around actually a very gradual phased implementation over several years. And it is about appropriately resourcing the implementation of the system, so making sure you do have dedicated trainers to actually make sure the system is implemented properly. What we did is we actually implemented in one area in the organisation, and then you found that other departments were coming to us and saying, we want that system, because the word was spreading out. So once you've got engagement and people actually coming to you asking you for the system, then it's that you're actually halfway there in terms of implementation, but you do need to resource the training side appropriately. I'm not saying you can do that in the next 2 to 3 years, but I think you need to plan ahead over a 10-year period and be brave, and I think you will get there.
I'm just going to elaborate on that thing. We develop locally as well, in-house development. We try to encourage local IT or health informatics working in the hospital who they know more than the outside. We develop with jointly, because not all the hospitals the same. I can't take my system and implement it in my hospital. Very difficult. Culture. We have culture is actually bigger than the IT system itself. We have an elderly consultant there. They don't like computer, and they will put anything in that. New generation coming in with the iPad, you know, texting with that's much easier. I think generation have to pass, and then I think we will get there. It can take quicker by having the resources in Libya. You need to train the staff. I'm not sure how many health informatics here at all. Does anybody raise hand for health informatics? 1, 2, 3, 4, 5, you know.
Let's have
Sorry.
people are burning to have intervention from that side. So can we have there, and then we can
Yeah.
listen? Is that okay?
Sorry?
Can I ask 3 people who are very keen to say something?
Yeah. Sorry, I haven't done Adil. I mean, mortality is very, very interesting. You really need to work inside your hospital and find out first what's happening. And you can't just use data. Data is very difficult, you know. So, but these are you can improve with IT. This is like only small things. I mean, you can do at hospital level. You can do a lot more. There is a lot of early warning system you can build into your system, and you can reduce mortality. We have junior doctor who have potassium. We have problem with potassium, you know, hyperkalemia in the hospital. In the UK, can't treat it. New junior doctor, not, you know. So there are a lot of things we can help with that. We develop some system that use iPhone, use iPad to alert the doctor when some abnormal result comes in. In the future, we'll use health informatics. We use mobile phone to actually alert you. You will go to the computer only when there is something you need to check. That's what the future. Thank you.
What I will do is now I'm going to ask for 3 people only. I know who the 3 are, so yourself, and the gentleman at the back. And we'll start with the gentleman at the back, and then we'll come to the front. And please make brief interventions.
Yep.
Otherwise, it'll be at the cost of your lunch. So, okay? So keep it very, very brief, okay?
Thank you. My question is brief. The abbreviation HIS, it could mean health information system. It could mean hospital information system. My question is there a centrally clear definition of both? And if there is so, is there a body that controls the information coming from hospitals to integrate it into the health information system? And what is exactly the relationship between them? And what about the logistics of arranging that? Is that a political decision or a professional decision? Or in the UK especially, both of you are from the UK, so.
Okay. I'll
Thank you.
start, and if Ali wants to.
Wait,
sorry.
we have to take 2 more interventions. Please, go ahead, sir. The second row and then the first row.
Okay, that's the
Pathology centers have benefited from laboratory information management systems, in particular in cutting errors in blood transfusions and so on. I wonder if you could make a comment specifically on that, please.
I will ask you, I will tell you something about my experience, and then I want your experience. But before this, you're very fast. And before this, I want to ask you something. Or please, our lecturer, please don't tell us after 10 years, after 30 years, Libya will do so. Because we believe that we can do something very fast. Just depending on God, how we do that. So, my experience, I attended one electronic conference before the revolution, and we discussed some of the Americans who tried to do some electronic systems in Libya. And in our training as GP doctors, see, we were trained at the Royal College. And we asked them about their systems and how we can run the system. So all of them, they used to say, create your system and do what you think to do, and you can succeed. See, we cannot give you our system. So you get surprised in Libya that you find our ID cards with the chip, but they use it as intelligent information. So what do you think about your experience to use this ID card to put some medical data, and through this you can do the job in how to network these things? How can
I mean, start the first step, you see, without thinking about huge things. And I think I'll be back again to the professor when he said how to collaborate, not Ministry of Health, with the electronic people who's working in computer science to do this thing in Libya. So.
I don't know, can you hear me or not? In the UK, we have a lot of issue with the data, with patient data. So we couldn't just go for the chip thing. So there's a lot of data protection and all that. We have not done that. Well, you can use anything in here if you can. If you are the public would want you to do that, that's great, you know. I mean, we struggle with actually the number of duplication of patient in hospital with the same number. I went to Benghazi Medical Center, and they actually use fingerprints. Great idea. But I don't think you can implement it in the UK. Fingerprinting patient, you know, that's the kind of thing we're facing. So yes, you can have a system tomorrow, but you need to start now, small and aim big. You can have one of these clinical database systems and trial it, pilot it somewhere. Pilot it in Zawiya or in Tajura. They are existing there, not very expensive. And you need the main thing, we need Libyan informatic here. We need to start educating. It's not about training, it's about coaching. We need coaching. Training is not. Training and using computer, that's everybody using computer. Coaching, why are you using computer for? That's the main thing, okay? Sorry? Pathology data, unfortunately, I'm not the expert, but we use a lot of the pathology data. Pathology data account for 80 to 70% of all diagnosis and treatment. So any treatment or diagnosis probably require the pathology results. I use some of the pathology results for renal function so that I try to delay the dialysis. We have a system where our renal physician and the lab have 10 years worth of lab data, and we try to actually get the GB involved at early stage. We found that by doing that, you can delay the dilution for 3 years.
Okay, let me come in because I think I don't want to set the next chair who's going to come and sit here because we're already 15 minutes late into the session.
Okay.
Do you want to have a last word, sir? And then I think we will just close the session and I will stop.
I just wanted to pick up on the first question about health and hospital information systems. I concentrated on hospital information system because I work in a hospital, but I could have spent a lot of time talking about health information systems, and we're going right down to what primary care level and below that. And basically, we've got a national information authority who actually is charged with managing all health information on behalf of the NHS. So they get data extracts from primary care as well as secondary care. We do struggle because we've actually been pushing the agenda in terms of actually getting more robust data out of primary care, because somebody mentioned earlier that GPs are independent contractors, and there is an issue in terms of the GPs releasing their data, and they're actually combining the GP data with the hospital data and also the ONS death certificate data will give you a really rich picture then in terms of what's actually happening in the population, and that's something high on our agenda, and we're trying to influence the Department of Health and the Information Authority to make sure that that data is actually released and brought together. Thank you.
Okay, thank you very much. Let's close this session on information systems. Just remember there is a 4-hour session over the next 3 days on information systems, so those who have not had the opportunity, you will get that opportunity. I just want to close by making one sentence of what I needed to say. We have heard a lot about clinical aspects of information systems, but when you are designing your information systems, don't overlook the management aspects of your information systems. That is as important as the clinical. And so there's a lot that can be said about it, but I think I'll stop here and I will pass it on to our next chairs to be able to run the session on service delivery. Thank you very much.
Our discussion is going to be on health system deliveries, and just a general overview of the concept. It's a system delivery of some sort that would be divided in a input, process, and output. The input is the constituents of this system that you wanted to deliver. That includes the human resources, includes the finances, includes the plans in which you're going to implement to come up with the services. And then how you're going to cook these constituents is the process. And at the end, after you finish the cooking, it's going to be the outcome. The outcome usually is measured with certain things that we can measure, not just a subjective feeling that our process has succeeded. And then, of course, in our case, in health system delivery, we would like to, at the end, look at the impact. And the impact is decrease in morbidity and mortality. Without any further ado, I'm going to have the 3 speakers start. We have distinguished speakers on this topic. First would be Dr. Samir Al-Sagar. just a housekeeping note. Please keep the chatting to a minimum, and please reminder to turn off your cell phones.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين.
Professor Sagar, can just we introduce you to the audience, please? Professor Samir Sagar, he is an BCH graduate of Tripoli in 1981. He was postgraduated in Libya and UK. FRCS holder ED 1986 fellowship experience in orthopedics. UKC consultant orthosurgeon since 1990. Worked in Tripoli Central Hospital, Trauma Hospital, Tripoli Medical Center, and former head of orthopedic department in the last two hospitals. Also a professor of orthosurgery, Tripoli University. Please start, Professor.
Mr. Chairman, ladies and gentlemen, first I would like to thank the scientific committee for asking me to talk about the clinical service in Libya, a clinician point of view, of course. What I thought I'll do is to, I'm sorry, this is the wrong slides. Sorry about the mishap. Briefly on the history and introduction of the topic, and then I'll talk about the current status in the pre-revolution time, that's 2010, taking into consideration the primary health care, finance, resources, medical, legal aspects, teaching and training. And then at the end of each, I will put a brief remark and end my talk with a conclusion. Over the last 60 years or so, there has been many metamorphic transformations in the form of demographic, socio-economic, and health care evolutions. The healthcare service in Libya has passed through a number of stages of adjustment, growth, and development. The major emphasis was on the individual patient's care until the 1970s, and then it moved to community health facilities. And after the 80s, a slogan of health for all was raised. The national health policy declared provides a framework for the national health strategy in accordance to which the health programs are designed and implemented to deliver medical care to all citizens. This responsibility is contained in the Public Health Law number 106, but beforehand there was a public health law during the kingdom, which both were stated that the health is a lawful right for all people and is to be guaranteed to them by the state. It also put the provision of supervision for public and preventive health care. The 3 years plan of 1973 witnessed the implementation of the law, resulted in a huge geographical expansion of the health facilities, especially the hospitals and all the provisions. But then the 5 years started in 1976 was endeavored for the raise of the standard of living because of the increase of the oil prices. The 5 years plan in 1981, although aimed at the health for all and quality to quantity of healthcare service, it was not very efficient. The 5 years plan of 1986 had to be frozen due to problems of all revenues, as we know, and there was no plan since. In fact, in 1994, the plan has to be redesigned, and all the healthcare activity was moved to the level of governorates. The mean of implementation of healthcare provision was through 5 levels. The first 3 levels are primary healthcare levels: units, clinics, units, centers, and polyclinics. And then the 4th level is different types of hospital, from rural hospitals to general hospitals and central hospitals. And the 5th one is the so-called specialized centers. My source of data has been the Health and Environment Annual Statistical Report of 2010, based on the latest administrative divisions of Libya, to 23 provisions, or the governorates. Now, I have to warn you that a lot of these data are not true, and I'll go through some of them, but we have to have a source to discuss, I think. This table just represents the population of Libya in the different regions, and it is quite clear that the coastal area is more populated compared with the southern part cities. You've heard already that we spend around 3.5% of the GDP. The fund of the healthcare has always been mainly public. The total amount of spend is around $504 per capita. It has only been once more than the global target of more than 5%, and that was in 1996 when it reached to 7%. Note also that this is not true at all. It says here that the out-of-pocket expenditure is only 12%, which I doubt very much. Although we have improved since 2006 to 2010, but we obviously spend almost 1/10 of what the Americans do and 1/4 of what the British. So it's quite a low. Regarding the primary health care, you see that we have many types of units here. It says unit type A, B, C, and then we have units, we have the centers, the primary health care centers, and then we have the polyclinics or the combined clinics. And so we have at least 5 different categories. The biggest element in the primary health care are the centers and units, as you would see from the graph. And although the population description of coverage of each unit and centers are different, and the polyclinic are different and well specified, but the function description of each are more or less the same. They are doing the same function in the units or the center or the polyclinic. The primary health care has done very well in the field of vaccinations, satisfactory to some extent in terms of school health and issuing the health certificates, but it has done very poor in terms of management of bumps and lumps and minor illnesses. This is reflected in the huge influx of patients coming to hospitals and even to specialized centers for very minor problems. These indicators that you see on these tables, if they are true, they are not reflected on the society. As it has been estimated in one of the reports in 2007, I think, that around 3 million Libyan people are treated outside the public health service. Now let's have a look at the distribution of all these facilities of primary health care over the regions in Libya. And you see that the health units and centers are nicely distributed. This increase in the low populated area is acceptable. In fact, it's favorable. You'd expect centers to take care of less people in the less populated areas as compared to the densely populated areas. But this is not true for the polyclinics and for the dental clinic. You see that they're only scattered in few places and not the others. And that's what I meant by saying they're doing the same function, but they've been put in different places. Therefore, it just makes sense that if we have just one level of primary health care, so that they're all distributed and all over the country, at the same time, they're doing the same function, i.e., something like this, where you have a primary health care under the local authority, and then you have a regional hospitals under the Ministry of Health, and perhaps the specialized hospitals or centers are under the university level or so. Right, that was for the primary health care. Regarding hospitals, this table shows that we have 97 hospitals with more than 20,000 hospital beds. That accounts for 37 beds per 10,000 citizens. Now, we all know that a lot of these hospitals are not functioning. They are under maintenance, they're closed. As a matter of fact, when I looked at the details of the hospitals, I found that Salahuddin Hospital is still on the list, which is ages ago, and Misrata Hospital is again on the list, which was closed 3 years before the revolution. So it's very doubtful. But if we look at the distribution of these hospitals, we see that they are evenly distributed, acceptable, except perhaps for the area of Jfara. And I think one reason for that is that Zahra Hospital is meant to be a district general hospital for that area. And for some reason, it has been changed to a specialized nephrology center or so, and that had affected the distribution badly. I think Zawi as well is less than one hospital per 100,000 population as compared with the others. Right, if we split the hospitals, as you see, these are the specialized centers. You see that they're concentrated mainly in Tripoli and Benghazi, and this is expected. These centers are serving the population of all Libya. So that's acceptable, and the rest of the hospitals are evenly distributed. Now, one observation is that the hospitals in Tripoli and Benghazi, in fact, are even at the level of the general district level. They are actually treating patients coming from the cities far and nearby these big cities. So there is an overstretching of the resources of these two big cities as compared to the peripheral cities. This table shows the rate of hospital beds per 10,000 citizens, which says 37, and it's compared with the neighboring countries. Again, 37 beds per 10,000, we're almost the best around the countries in the regions, but a lot of these beds are, as we said, are in closed hospitals, and if hospitals are open, if you check the occupancy rate, you'll find it's very low, a very low turnover. Adding the other fact that when we talk about the nurses and doctors, if you have deficiency in nurses, in Libya, those wards will still open. In developed countries, if you do not have enough staff to run the beds, then you close wards. This does not happen in Libya. Now, if we compare with the international or the Western figures, we are not too bad at all, if the 37 beds per 10,000 population is true, of course. Now, if we look at the distribution of these hospital beds among the different regions in Libya, we will find that they're evenly distributed. The same little problem with Jfara. Now the human resources, this table shows the number and rate of doctors and nurses per 10,000 citizens in both primary health care and the hospital service. This does not tell us about the seniority of the staff, nor it tells us about the specialty of these staffs. Likewise, for nurses, it says that we have 71 nurses and midwives per 10,000. Now, we know that a lot or many of these nurses have never been to a nursing school. A lot of them have been qualified from a 1 week to 3 months courses, quick courses for, you know, for anybody who wants to learn something about nursing. And then the problem, once they are enrolled in the hospitals, they will be treated like any other nurse in the hospital. We don't know how many of them are ICU nurses or theater nurses. It just says nurses and midwives. Now, if you look at the distribution of the staffs, we're quite all right with doctors. Nevertheless, you should know that many of the doctors who are working in the peripheral hospitals are foreigners with degrees that has not been verified by any body in the country, and for this reason they tend to be a lot of cases be referred from these peripheral hospitals to the hospitals in Tripoli and Benghazi and perhaps in other big hospitals. So again, it doesn't tell us about the experience and specialty of these doctors.
5 minutes left, Professor.
Regarding nurses, you see that there are more nurses per population in the low populated areas, and I think the explanation for that is the easy nurse job you can get if you get a 1 week to 3 months course, and also the fact that most of these nurses are females, and it's a bit difficult for female to move, or female nurses to move from outside peripheral cities to the main cities. They tend to stay where they live, and that's why we have a higher rate for nurses. On the other hand, the rate of dentists and pharmacists, as you can see, are more in Tripoli and other coastal cities, except perhaps in Misrata and Tobruk. Now, if we compare our data with the other countries in the region, you see that we have more doctors and nurses per population compared with Morocco and Iran, but more interestingly, we're more compared with Tunisia, where a lot of our patients are being treated there. I'll just go quickly through the private. It says that the official data says that only 12% are out of pocket. As we said, that cannot be true. And this table represents the different facilities for private, from hospitals to clinics to laboratories. And this represents the number of the private facilities. You see that they're mainly pharmacies. The light blue are the private pharmacies, followed by private outpatient clinics, and the least are the private hospitals. Now, if we look at each over the years, all the facilities has increased over the years, except private hospitals, where it has reduced after the year 2005. This is possibly because of the high competition between the hospitals. They could not stand, and also because of the contract of 2005, where it has been prohibited for doctors to work in both private and public service. Now, we know that in developed countries where they have a good public service, the patients tend to seek private service in some dental service, some plastic surgery other than congenital, or some special medications. In addition to if anybody wants to jump the queues, or he wants special treatment in terms of rooms and others, or if he wants to choose the surgeon who operates on him. But in Libya, the problem that patient seeks private medical advice and treatment because they cannot find it in the public service. I brought this slide just to show you that although the commonest cause of disabilities in this report says that it's congenital followed by post-disease and then comes injuries, I think following the revolution, this might change a bit, and we see the number of disabilities in the injured quite high. As far as the age is concerned, I think this will stand true, because the injured revolutionaries are mainly in this age group. Medico-legally, I wanted to put this slide because we want to make sure that the law for the medico-legal liability in Libya should be discussed during this conference, because it practically says that the doctor is he will have to prove his innocence. He's guilty until proved otherwise. Unfortunately, the doctor himself will have to prove that. These are the cases and presented in this chart. The highest, as everywhere else, I think, is the gynae-obstetrics specialty, followed by other surgical specialties, and the least is dental and ENT. Now you see that the proven liability is too small compared with the unproven ones, and that, you know, because it's very easy for a patient to sue a surgeon or a physician, and then the surgeon-physician will have to prove his innocence. Lastly, a quick look at the number. Again, I'm sorry that all these data are more quantitative and not qualitative, but I think we can just throw some conclusions out of it.
1 minute left, please.
Okay. It says here that we have around 500 graduates from the Libyan Board of Medical Specialties, and mainly pediatric general surgery and internal medicine, and there are around 5,000 trainees still waiting to to finish their training. 3,000 of them, they had their part 1. As far as students in Libya, we have 9 regions, 6 schools, from medical school to pharmacy to dental to others. We have a total of 63,000 students in these schools. In Tripoli alone, there are 30,000 students in different colleges. And in medicine in all Libya, there are around 25,000 medical students in different universities in Libya. Now, although these numbers are quite high, the problem is not really the problem is the quality that we should take care of. This graph shows that this is the number of employees that we have, and this is the number that we should have if we are to reach the global target now. And this is if we are to meet a 10 million population at 2025. So the number is huge. We can accommodate a lot of, or we can absorb a lot of these human resources in the future. Mr. Chairman, ladies and gentlemen, I would like to conclude by saying that I think the priority is to have a good health information system and hospital information system where we can have all the necessary informations to analyze. And I think it's time now that we have a healthcare system with a well-defined payer and provider and an independent evaluator or regulator. I think it's time that we have a clear job description for all jobs in the private and the public service sector. We have to have a function description of all the facilities, all the hospitals and primary healthcare units. We I think it's time that we have a centralized planning and evaluator, but a decentralized health care provider. And I think we should be able to correct the number of staff deficiency over the next 10 years or so. And we should build and plan a rehabilitation centers and programs for the injured and disabled persons. Thank you very much. Assalamu alaikum.
Thank you, Professor Sagar, for your presentation. Please, we will keep the questions after the last presentation, just to save time for your lunch. The second presentation, Mrs. Erhola, please.
Yes. Sorry for the interruption, just an announcement. Anybody got a problem with tickets, either for the overseas doctors or for the local doctors, there is a table just in front of the room with the red cover on it. Please come and contact us there so we can solve the problem. Thank you.
It's a great pleasure to introduce Dr. Marina Erhola. She's a PhD holder. Dr. Erhola is the head of the Division of Health and Social Services at the National Institute for Health and Welfare in Finland. She is going to deliver a speech on primary health care centers versus GB services. Dr. Erhola, please.
Mr. Chairman, dear colleagues, first of all, I would like to ask how much time I have. Okay, thank you. I was giving the topic of my afternoon lecture is primary care centers versus GP services, an unnecessary contradiction. And I was trying to fit this presentation really into the title that was given to me, because I understood that in Libya there has been a lot of discussion about whether it's the system that matters or whether it's the GPs that matters, and actually it's both, but I try to say a few words on that. So what is primary care? We start with this. We know that the most commonly used agreed definition is probably the Alma-Ata Declaration from '78, which says that it's essential healthcare, universally accessible to all community members with community participation. And importantly, at a cost that community and country can afford. And here we come to the country adaptation that I was already talking in the morning about. It is the central function and focus of health system. And this cannot be overemphasized, I think. At the time being, we have many, many countries in Europe also, in Northern Europe also, which are struggling with the fact that they neglected the importance of primary care. Indeed, it is important. It has to be highly appreciated. It is the first level of contact of individuals, the family and community with the national health system. And it needs to be as close as possible to where people live and work. And it is actually first element of a continuing healthcare process. 15 years ago, when I was young, probably a little bit arrogant doctor that had just specialized my training on pulmonary medicine. I had been in scientific work and had finalized my doctorate thesis and so on. And I went to an international course to study primary care because I started to be interested about that. Then the lecturer asked me, Marina, what do you think that is primary care? And since I had my clinical background in hospitals, I said, oh, it's kind of a screening place where you just see people and then refer them to upper levels. And the lecturer was saying, really, is that indeed what you think? I said, yes, that's what I think. And so now I've changed totally my own mind. And I would like to convince all the clinicians who are here from specialities that actually primary care is much more than a screening place. It is really the cornerstone of the whole system. Primary health care is first of all a system. this is important, it is a system. It's primary care applied at population level. It is evidence-based also, as any other specialty in medicine. It should be multi-professional teamwork. It should be delivered via health centers, as we were just nicely seeing how the situation is in Libya. You actually have quite good skeleton for the primary care systems. It's person-focused. It's not disease-focused. This is the main difference between other specialties of medicine. Primary care is focusing on the person with his or her diseases, whereas the other specialties are focusing on disease within the person. And this is clearly different. This is what makes difference with primary care and other specialties. And it clearly requires the commitment of the government to develop population-oriented primary care services. There are several models for primary care, different in each country. We have the so-called professional contact model, which is mainly seen as primary GPs working there quite alone, and then the population assessing them. Then we have the so-called professional coordination model, where there is care by GPs and nurses who are working also together, attention to continuity and division of work, how they are working. And then we have the most advanced way of primary care services, which is the integrated community care model, which is the most integrated and most advanced also. The main principle of primary care, it's important to understand. It's provision of care at first contact with the healthcare system. Continuity of care is the cornerstone. This means that the family or the patient would need to see the same physician or the same nurse time after time. If we have no continuity of care, it's not really primary care. It's very problematic if doctors keep changing all the time, as we have the situation actually in many countries, unfortunately. Coordination of care means that the primary level of care should coordinate all other care activities. Comprehensiveness of care, which means that it includes prevention and health promotion. It's not only related to how we treat diseases. And via these 3 C's, we actually avoid unnecessary referrals, and we then don't have the hospitals overloaded, for example, as you have at the time being in Libya. Some of the main principles, I just took of 2 pictures here. The picture of this nice Finnish child having vaccination done, because I know that in Libya there is a very good vaccination system. You seem to have an excellent vaccination system. And while we were visiting here in April, we were wondering very much whether you could actually develop your primary care around this very nice working vaccination system, because it seems to be quite strong. And then what you actually don't have at the time being is the gatekeeping system. You have no referral. You have no obligatory referral system from primary care to hospital care, which also means that your hospitals get overloaded. So remember these 2 pictures, the gatekeeping role of the primary care in the future, and then the good vaccination program you have. Maybe you could develop something around there. This is just an example of Finnish primary health care. We have the community-based, everything is included more or less in primary care, starting from school care to X-ray laboratory services, even we have some beds there and so on. But every country differs here also. We know by evidence that primary care-oriented countries have fewer low birth weight infants. They have lower infant mortality, especially postneonatal. They have fewer years life loss due to suicide. They have fewer years life loss due to all external causes. And they also have higher life expectancy at all ages, except at age 80. So why is it so difficult to have enough focus on primary care? I don't know. It just seems to be so, that it is quite difficult to get enough resources to the primary care, but it's crucial, otherwise we fail. Especially with the aging population countries as we are facing this significant problem, but also in other countries, it is the cornerstone. Then about the general practitioner's role. I will try to convince you that it is important to have a strong system for primary care. But it is as important that we have highly motivated, qualified general practitioners. Also, the medical society has to respect them. Also, in all countries, I think we are facing problems with this. We don't respect enough the GPs. They are the ones who have the most difficult task, I would say. It's the most difficult work in the world, you know, to see any patient who comes from the door just with any symptom and try to make some sense of that and also take care of that. So we need to respect the GPs much more than we do nowadays. The GP offers continuous and comprehensive facing problems with this. We don't respect enough the GPs. They are the ones who have the most difficult task, I would say. It's the most difficult work in the world, you know, to see any patient who comes from the door just with any symptom and try to make some sense of that and also take care of that. So we need to respect the GPs much more than we do nowadays. The GP offers continuous and comprehensive care and serves as a coordinator. It's just not something small things they are doing. They are coordinating, or they should be coordinating, the whole care process. And this is a difficult job. We need to respect it. The crucial dimensions of the GP services are in forefront. They are the first place where the patient should be coming. And they should not be actually referring themselves to hospital level of care without seeing the primary care first. This is the European definition. I actually like quite much this tree because it, in a way, shows that GP is very much. Being a GP, you have to understand quite many things. You need to have the right attitudes towards the work. You need to know scientific basis. You need to know the context. But especially you need to be interested in a person. You need to be interested in person, in human being with all the diseases. Not only interested in the disease in a person, but person with the diseases. So from there we come to the tree with primary care management, community orientation, comprehensive approach, holistic modeling, and all of this goes then into the leaves of the tree. So if we understand the fundamentals of this picture, I think we understand quite well how important primary care is and also how very, very difficult it is. So nowadays, the global imperative is to organize health systems around strong patient-centered primary care. And why? Because a disease-by-disease approach will not address the most serious shortfall in achieving the health-related Millennium Development Goals. It will also worsen global inequalities. So those exposed to a variety of interacting influences are vulnerable to many diseases. So eliminating a disease one by one will not materially reduce the chances of other diseases. So it is, dear colleagues, it is of paramount importance primary care is. And all specialities of medicine have to respect primary care. They have to respect the GPs who are working under very, very difficult conditions. So we need to help them. All of us, we need to help them. So this is a picture from our last visit in April in Libya, and I could see these two nice, enthusiastic primary care doctors. They had believed in the system. They were believing that Libya can have a strong and good primary care system. And in another picture is myself about 15 years ago when I was this arrogant, just finished my pulmonological training and then started to study management. And I went into my first director's position to lead one primary healthcare center in rural part of Finland. And that job selection changed my medical orientation and my professional life fundamentally, because after that I've been for primary care, I've been for systems, and I've been for health systems management. Thank you.
Thank you, Dr. Marina.
Lastly, but certainly not the least, it gives me pleasure to introduce Dr. Andrews Valence Owen. He's a surgeon by trade and an international healthcare specialist. Dr. Owen recently was the CMO of the Bupa company, and currently he is the chairman of the UK Trade and Investment Healthcare Business Group, and he does have the daunting task of bringing together the private and the public systems. Without any further ado, Dr. Owen.
Thank you very much indeed, Chairman. And thank you very much to you all for staying, for waiting for me when your lunch awaits. I know I'm standing between you and your lunch. Thank you very much indeed for inviting me to come and talk to you today about private-public partnerships. I want to make it quite clear, I'm not trying to sell you the way we do things in the United Kingdom, as some people have been concerned. I've just been asked to talk about how we do it, in case it might be of value to learn about that in this country. As you heard earlier on from Nick Tomlinson, the National Health Service is the foundation of the UK healthcare system. And not only the foundation, it is the major part of the UK healthcare system. But like any system, it needs improvement, it needs new facilities, it needs more space for new demand. All the time there are new challenges. It can't do everything by itself. And this is where private-public partnerships should help. And you should understand that the private sector has quite a role already to play in the National Health Service. For instance, the care of the elderly in care homes. There are 21,000 care homes in the country. And, 21,000 care homes in the country. They are all provided privately. So that is care provided privately for the UK healthcare system. A lot of prevention work and health promotion work is done by employers in the private sector supporting the National Health Service. So, but let's talk now about the principles involved in private-public partnerships. And I think it's really important to understand what we mean by a partnership and what I think most people mean by a partnership. It's a relationship, as it says there, based on agreements reflecting mutual responsibilities in furtherance of shared interests. And the aims, as you can see on the slide, are there. The whole aim of a private-public partnership is to have clearly specified goals, a clear delineated responsibilities for both sides, distinct benefits for both parties. It needs to be a genuine two-way relationship where both sides need each other equally. It has to have a perception of transparency, and equality of participation is very important for parties to believe that they are working together. I'm going to show you, as I go through, a number of pictures of buildings being produced by private-public partnerships, just to give you some photographs to look at as I go through. This one, the new Children's Eye Centre for Moorfields Hospital. There are various types of private-public partnership in the United Kingdom. The Private Finance Initiative, which Mike mentioned earlier on, I'm going to say a little bit about. I think that's probably what you're particularly interested in. But there are other joint ventures as well, particularly in primary care, which you've just been hearing about, the Local Investment Finance Trusts, LIFTs. I'll say a bit about that. But also there are some partnerships right up at national level between the Department of Health and organisations. One, for instance, on health information, which we heard about earlier on, with a commercial company called Dr. Foster, to make sure that there is a combined approach for the use of healthcare information, a partnership with the Department of Health's Information Centre. And then, of course, there are contracts. Every healthcare system has contracts with suppliers, consumables, pharmaceutical products, and I'll just say a few words about the principle of that. And then occasionally there are also contracts for treatment and care. Most of the contracts don't actually involve actual treatment, but just in the last few years there have been some independent, some private sector treatment centres which have helped bring some competition to the provider side of the National Health Service and, if you were, to take the load off. So there's another picture of a PPP, the redevelopment of the Royal Marsden Cancer Hospital campus. So let's talk a bit then about the Private Finance Initiative, the PFI initiatives, which has been a backbone of new capital projects in the National Health Service for the last few years. what happens is you create private partnerships by funding infrastructure products with private capital. So here the private sector finances and operates the infrastructure, not the clinical side, through long-term agreements, often maybe 25, 30 years long. And payments are only made by the National Health Service, if you like, if the services are delivered as per the agreement, so a lot of work goes into those agreements. And what happens is the agreements transfer substantial risk to the private sector organizations in return for the payments over the 25 to 30 years. The UK PFI program started in 1992, and now there are over 120 major hospital schemes funded through PFI. The total capital raised to build those hospitals amounts to £11.6 million. We double that for dinar, so 22 million dinar. But the total repayments over the 25 to 30 years come to more like nearly 80 million pounds. So you can see it's quite an expensive way of raising capital. And that commits the taxpayer, of course, those agreements to spending that money over the life of the contracts. But the National Audit Office, an independent audit office in the UK, has shown that PFI projects are more likely to be delivered on time and on budget. In 2003, they did a study which showed that non-PFI projects, projects funded purely by the public sector, 70% of them were running late and 73% of them were running over budget. There's a much better record with PFI projects. There are various partners that